I'll say I think this is the first time I'm wearing a non-logoed work shirt for the podcast.
I think this is the first time. Well, no, I've worn other ones.
Yeah, you've worn a variety. You've worn a variety of stuff. If you can't tell,
I like owls.
Michelle loves owls. It's kind of a thing.
Yes.
It's a lot of a thing. She likes to pet all the things. She'll probably die from petting something that she shouldn't.
Yeah.
But if she could rescue owls for a living, she would do it.
For the record, if I'm ever a trauma or severe medical patient, just go for my EJ or IO.
She got shit for veins.
I speak the truth.
Yeah, she does. She does. So, anyway, welcome back, everybody. Good to see you. It feels like we just recorded like yesterday. It feels like we literally just did this.
I'm trying to remember when we recorded. I mean, it's been hella week.
Yeah, I think it was about a week ago.
Yeah.
Maybe even more, honestly. I think it was last Tuesday.
But it's been hell of a week.
Yeah, yeah.
Our patients have been sick as shit recently, y'all.
Yeah, it just seems to be the season for all that shit. And I'm medicated now. Well, more medicated, I should say. I've been resistant to the blood pressure medicines for a while now, and finally decided to give in because my pressures aren't running like high, but
It's high.
It's higher,
Mm-hmm.
and it's becoming more consistent. So, anyway, it's actually kind of interesting because I'd resisted blood pressure medicine for so long because there was a lot of the traditional meds that I was like, I really don't want to use that.
I've seen all the side effects of this.
Yeah, I'd really rather not. Like, whenever I see a patient with this, they also have this and this and this and this and this, and I really don't want all those things. So, anyway, the med that we opted to go for was one that was new to me. I'd never heard of it. It's called guanfacine. Facine. There we go.
Fuck your zine.
Right. It is a alpha 2 adrenoreceptor agonist, and was originally used for treating ADHD in kids. And it's kind of like ketamine, depending on how you dose it, is which direction the effects go or how potent the effects are. So, but it is used for adults for both blood pressure management and
ADD.
ADD. And since I'm
It's kind of similar to Cymbalta. Cymbalta was originally, I honestly couldn't even tell you what it was originally for, but now it has like 30 off-label uses because they found based on dosing, it helps with a bunch of different stuff, including chronic pain, mood stabilizer, all the things.
Well, and it's not something that I was used to hearing. Like, I can't even remember ever seeing it on like a patient's med list or anything. Like,
I've seen it.
Really?
But it's less common.
Gotcha. Well, and I was a little worried because, again, typical stubborn male. I haven't had a primary, an actual primary doc for a long time. I would always kind of fake him out. Be like, oh yeah, I'm looking to establish just because I need a physical or something, and then never see him again.
Hi, him. He's the problem.
Yeah, it's me. But anyway, so getting situated with this doc, I was like, well, we'll see how he feels about this because, maybe he's gonna be like, well, no, I'd rather you start on something else, and if you think you've got ADD, then we should probably, go another route. Which we figured he wouldn't because you know him, but. Anyway,
we originally met him when I went to see him. I was already established at the practice, but we went to see him, and Daniel came with me, and he's one of the docs that we walked in. I was like, Doc, I know I have a dry cough. I know that's my only symptom, but I'm telling you I have pneumonia. And he's like, what the fuck? And I was like,
how do you do this?
Right? I was like, listen to my story of what happened last year. I'm telling you I have pneumonia. And he was like, cool. You know your body. Let's go. He ordered all the tests. He ordered the chest x-ray. And guess what? I had pneumonia.
Mm-hmm. The pneumonia.
Well, so that's just kind of what's gone on this past week.
Well, and it's just the last bit of that story that I thought was funny was, I figured going into it, it might get a little resistance, might try to talk me into something else. And I explained my reasoning to him for being interested in it. And he was just like, oh no, I take it too for literally the same thing. I'm like, this is cool. Awesome. He's
like, I like it.
Yeah. I was like, sweet. Because I didn't want the normal ADHD meds either because, oof.
You don't want meth?
Well, no. Clearly not with my blood pressure. I don't need any more help.
No.
But but I don't like my brain to be too quiet. So apparently he said this is a good middle ground. Just kind of slows the activity down just a little bit. So
you can organize it.
Yes, it's easier to organize the flow coming in. So anyway, we got a couple of things to talk about today. Let me pull up our notes. So something that has been an ongoing topic. Honestly, this has been an argument for all of my career. The pros and cons of having permanent partners versus rotating partners. And it's come up in conversation with some people, and I've noticed more recently that people are becoming more defensive about it. And they're very, like, I understand you have people you work well with. You want to keep working with them. Like, if you're an effective team, cool, I get that. I kind of feel, I don't even think you can make a rule about it. I really don't think there's a solid rule for one or the other, or for determining. It's not there's not a one size fits all answer to whether or not you should be permanent partners with somebody, or how that process goes.
Yeah, I mean, so we collectively have worked at places. So there was one place where on 12-hour shifts, you would go to a new station with a new partner on 12s every single shift. There was, at that same place on 24s, you would work at the same station with the same partner for 1 month, and then you would change to a new station, new partner. And then we worked at another place that you would rotate even on 12s partners and stations. I think it was monthly, wasn't it? And then there were some people that had like their permanent trucks. It just kind of depended on the time slot.
Yeah.
Now with our current jobs, we have permanent stations. Granted, we don't have partners right now, but we still have permanent stations on permanent shifts.
That's actually not that
bad. No.
I love all of my previous partners, but it's kind of nice being by yourself a little bit. But anyway.
And I understand all the arguments. If you work with a permanent partner, you get to know each other. There comes a certain point where you can work almost completely without speaking. You know each other's strengths and weaknesses. But honestly, if you're not job hopping and you work at a place long enough, when one of the jobs that we worked with that we did rotate partners on 12s, I worked there long enough that I worked with all the partners enough. I still knew them well enough. And I knew who I liked. I knew what to expect. And we still all worked well together.
Yeah.
If you're changing jobs every 6 months and you're consistently changing partners, then you're never going to learn anybody. So I think it can work in favor of both, because if you get too used to and too complacent with the same partner, you're not going to grow. You're going to end up holding each other back.
Well, and I think it depends on where you are in your career too.
That's fair.
And I have to throw this in there too. We're talking specifically in the context of EMS, because I would argue very much that in the fire service you should keep everybody together as much as possible, because they have so many more technical group skills that they need to master, and not just master objectively, but as a team they need to master them. That I'm 100% down for. I love it if I hear guys who are, coming from a firehouse where they've had the same partners for 20 years.
Yeah.
That's fucking awesome. Absolutely love it.
Yeah, this is specifically EMS.
Yeah. So for me personally, I think when I was a new provider, well, specifically new to 911. So when I was first certified as an EMT, I had, I want to say it was like a year and a half of just a little over a year of convalescent experience. And at that point you're working with whoever. I had multiple partners.
Partner soup.
Yeah, which was fine. I mean, it was good. It was a fun experience. I liked a lot of the people I worked with for the most part. But when I started doing 911 full time as a young EMT, I would basically, the way they had it set up is that if I remember correctly, it was the paramedics rotated down the schedule, the EMTs rotated up. So they had an opposite rotation of each other. So, but we would rotate a month at a time. I really liked that. I really liked that because it gave me time to get used to somebody and learn from them, learn their habits, and then switched and learn somebody else. One of the medics that you interact with a good bit now was one of those early formative paramedics for me. Which is so funny now when she'll call me for backup. I'm like, but why? This is weird. But anyway, so I think at that time in my career, that was great. It was really great. But then as I got more, I guess you could say, comfortable in my own skin, which I never really felt like there was a time as a brand new medic that I was like, oh, we're uncomfortable, like, the sheepish kind of vibe. Just as I got more used to my job, I was okay with shifting between multiple partners. I actually liked it. I had the way the schedule was set up, then I would switch each shift. So we would basically have a 4-station rotation, and I had 2 partners that I would alternate. So one, of a 4-shift cycle, one partner at one station, switch partners to another station, go back to that first partner at a different station, and then the second partner at another station. So I liked that. I got into a good groove with them, but we communicated well. We worked in a fairly urban area, so it was pretty easy for us to turn and burn calls, and we did well. We all did well together. But
Well,
go ahead.
and that's where I think we're kind of going. So there's not like one rule or way to do shifts and partners and
Yeah,
stations and all the rest of it that like fits everybody. The problem that we're consistently seeing in EMS, which is culture, attitude, pick a word, but it's a fucking problem, are the people that feel entitled to sticking with the same truck at the same station with the same partner, or they're not going to work. There are not several, there are two very distinct examples where it becomes a problem. So if you have a partnership that they work at said station on the said truck, and one of them has to do a shift swap because of something with family or, another job, whatever, they're not able to work that shift and a part-timer fills in, and then the other full-time partner that is still supposed to be on the schedule, like, an hour before shift starts, calls out. Sure, people get sick, but when it starts to become a fucking pattern and they never work with that part-time person and they're only ever sick when the other person is not working and they actively refuse to split up as a partnership, that's toxic.
yeah,
Especially if,
yeah,
it's a BLS ALS combo, like an EMT and a paramedic partnership, and you get too comfortable with each other that it turns into, oh, well, you're a competent EMT. So, like, this is like BLS with a EKG, but like, I'm not actually going to do the EKG, like, because you're a strong EMT.
yeah,
That's not appropriate.
yeah. No, that's bad medicine.
Yeah, that's not okay. But over ALSing things because, you're not comfortable with your assessment skills is also not good either. It's not good for you as a paramedic. It's not good for your EMT partner, especially if they want to go to paramedic school. Like, let's not give these new providers bad examples.
Yeah,
Another situation that we routinely see is if you're going to be at a service, sure, you're going to do what's best for all of your providers, or ideally you're going to do what's best for all of your providers, but we still need to have some kind of standard of practice.
yeah,
So if you have a double paramedic crew, and then you have a double EMT crew, and the EMTs are going to paramedic school, and they're being told by upper management, hey, you guys are such strong EMTs together. Y'all are the freaking best. But once y'all get your paramedics, we're splitting you up. Well, why? Like, you just told us that we work well together. Well, we're super short on paramedics, so we need to split you up.
uh-huh.
Well, I understand why the question is, well, why the fuck does this truck get to be a double ALS truck? And when fucking management comes back and says, because those two paramedics together equal half a paramedic, why the fuck are they still employed?
Well, what was it I said? When you put dingbat 1 and dingbat 2 together, dumb shit's gonna happen.
Well,
And that's
but
that's.
why are we allowed, like, if even upper management says that these two paramedics are such
Mm-hmm.
idiots that together they make half a paramedic and they do some questionable shit on shift, why is that allowed? Like, either break them up to put them with strong partners and fix them, put them through,
Mm-hmm.
remediation, or why the fuck are they still employed? Like, that should not be okay. But if you're gonna let the two of them together, then why are we saying, oh, we're short on paramedics and you and your partner who like working together, like, fuck y'all, you're not working together. But at the same time, if you're short on paramedics, get the fuck over it. I'm sorry, there comes a certain point where we are short on paramedics and you don't always get a paramedic partner. You have to be able to work well with other people. Oh, well, I'm comfortable with this person. Work with other fucking people.
Well, and that word right there, I'm comfortable with so and so. That is an exact sign that you need to have a different partner.
Potentially too
Complacent.
I was gonna say compliant. I'm like, that's not right. Yeah, too complacent.
Yeah.
So like none of these situations are good, but we need to have something consistently across the board. If you're gonna say no double medic trucks because we're short staffed, then why are the two idiots still together? You know, if it's these two people refuse to work with other people, cool. Tell them they're no longer partners, and if you don't like it, then cool.
Go find a different job.
Yeah, go find a different job. But like this whole getting butt hurt because you're not getting exactly what the fuck you want, grow up.
Yeah.
Like, I mean, seriously, grow up. Why are we throwing temper tantrums like we're children? There have been plenty of people that I didn't exactly jive with, but as long as there's not like detrimental to patient care, it's not a hostile work environment, you're not getting sexually harassed. Like, guess what? Shifts end and not everybody's personalities jive together. And there comes a time and a place where you love a person, but after working with them for a month, you're like, you don't shut up. Your nonstop talking was cute in the beginning, but after a month, I need some fucking quiet. Give me the person that doesn't talk.
Well, and in that second example you brought up too, and you have management saying, oh, well, they're basically incompetent, but that's why we keep them together so they can sort of kind of half work together. First of all, why the fuck are you saying that to your people?
Well, to other people.
To other people. Why the fuck are you saying that to folks that have nothing to do, ultimately, in a HR perspective, with those paramedics? You should not fucking do that. Period. That doesn't mean you need to outright lie, but that is inappropriate leadership right there. So that's my first problem with it. Second problem is, if you know they suck, why don't you fucking fix it? Novel idea. Shocker.
Well, and plenty of stuff that I have heard is, oh, well, they're on that truck because they know the area, they know all the people, they know all the cops, they know all the residents, all the roads.
Literally has nothing to do with it.
Agreed. But also, oh, well, they've been in public service for like 30 years and they're just set in their ways. Fucking
then
no.
They need to leave.
Well, I mean, at that point, it's like, okay, forced retirement. Or like, why are we holding on to dinosaurs that aren't keeping up with medicine? If you have your last two brain cells fighting for third place, there's a problem.
Well, it's not even just a question of keeping up with good medicine, like advancing protocols, just the basics of doing your job. Like, it shouldn't... Like, and this is not coming for either of us. This is not coming from a place of animosity towards, obviously we remove names of anything we talk about, but it's just an observation of, hey, these kinds of pattern behaviors are not healthy, are not helping our industry at all.
Well, it's toxic, and when you have the people that get complacent, and especially the paramedics start BLSing shit because they're like, oh, well, my MT knows how I work, and if I'm not worried about this, then they shouldn't be worried about this. It's like, that's not necessary. Like, and if you get to a point where you're like, oh, this patient is too young to have chest pain, even though, they had a baby less than a month ago and have hypertension, they had preeclampsia, and then you go pushing on their chest and she says, ow, you're pushing on my chest. Oh, it's musculoskeletal. No.
And a lot of times I have seen that happen. And again, just speaking categorically, I've seen that happen with a lot of medics who are basically throwing a passive-aggressive temper tantrum that it's like, oh, well, I'm writing the call, but I shouldn't have to write the call. No, I don't like having, I don't like being put in a position where I'm writing the call that I shouldn't have to. Nobody likes that. Nobody wants to have to do something that they shouldn't actually have to do. But be a goddamn professional and don't start, like, I mean, I'm not going to go hyperbolic and say it's, battery to your patients, but like, that's not appropriate assessment. It's not. Going on and just smashing on someone's on breasts like that? No.
Well, there's a time and a place to do a palpation assessment. Like, if they say they fell. If, they say they ran into something. But if it's general chest pain with symptomatic hypertension, why are we pushing on the chest?
You should ask patients consent before touching their chest. Doesn't matter the gender. You don't even have to make it a formal question, but explain it ahead of time. Like, hey, I need to palpate, I need to feel on your chest to see whatever you're looking for. That's appropriate. because it's not like we have to ask our patients, can I take a blood pressure? I hate when people ask that. It's just like, hey, let me go ahead and get a blood pressure on you real quick while we're talking.
Mm-hmm.
Do your job, but communicate and be a professional about it. And don't do something just because you're having a temper tantrum.
Mm-hmm. But wait, we've seen an uptake recently in getting attitudes if you don't get what you want when it comes to a truck. And don't get me wrong, we know that the spare trucks are usually spare trucks because they're shitty and it's frustrating
Mm-hmm.
if it's cold and they don't have heat and this and that. We're not saying you can't complain.
Which is technically a DHEC violation, but we'll forego that.
There's so many things we could be talking about.
Anyway, moving right along.
Especially if they're CAS accredited. Um, Oof, that's a whole other. We're not
Anyway,
going there. We're not going there.
So point
being, it's not about complaining that your equipment's not up to date, that your truck is not, whatever. It's literally comes down to if leadership is not being consistent about the reasoning for partner decisions, or you have the crews that are literally calling out to avoid working with part-timers because they refuse to work with anybody except the person that knows them. Get to know all of your people. There may be somebody who is staffed that you would actually get along better with than your current partner.
Mm-hmm. Well, and two, when you intentionally put people together, or when you don't properly remediate somebody who has established a history of inappropriate, subpar patient care, you're setting them up for disaster too. You're setting them up for lawsuits. You're setting them up for any number of things to happen to them. That's not right. Now, they're still accountable for their actions, but as leadership, you should intervene in that kind of a situation. That should not just be left unchecked.
Well, and something else that I've seen / heard. So we share our charts, like you're able to add other crew members on, for ALS Intercept and this and that and all the rest of it. Something that I've consistently heard is there are certain providers that don't like adding on other providers, such as me or Daniel or whoever, because they don't want you checking behind in their chart. That they don't want you, challenging. Either it's the activity log or interventions, even the narrative. And you can ask anybody. I am very thorough when it comes to my documentation. I would say not excessively. I do not double document, but
yeah, no.
I do due diligence and doing my job appropriately and thoroughly. So you get an entire big picture, but there are plenty of people that will literally only do the red flags and that's it. And something that I consistently see that's a problem with a lot of these crews that work together is they'll say that they did certain assessments that they didn't. And something important, actually, I think I have a video saved to do a TikTok on it, just to mention it. Don't document that you did a neuro assessment if you didn't do a neuro assessment. Don't document that you listen to lung sounds if you didn't actually do it. Yeah, you may say that the eyes are pearl, but really the patient has had cataract surgery and one pupil, is much larger than the other one and non-reactive, but that's the patient's normal. Because if you go to court, you are liable for that chart. Don't say that you did something. And I would argue that pertinent negatives are just as important, if not more important. I put more pertinent negatives in my charts than positive findings and symptoms because they help you justify ruling in or ruling out. Same with doing like med checks and stuff like that. It is almost more important than the signs and symptoms that you do find.
And I'm not as much of a Nazi like you on some things, like. I'm not referring to, recent events, current events, but.
Oh, no, I'm talking about.
Like, grammar Nazi, calm your tits, everybody.
I was just saying I'm not that bad.
But it's amazing to me how much work people will do to get out of doing the basic work of the job.
Mm-hmm.
If you can't be bothered to properly document your vitals. Let's say that, for example. Well, literally, what can you be bothered for? Like, what? Seriously, what can you be bothered for if you can't go the extra mile? And I love the argument Well, the monitor won't upload. Then print them off and put them in yourself.
Mm-hmm.
Guess what? I do that most of the time, even if I can upload it, because that's just my little ritual for most of the time.
No, I don't like having to take pictures of and upload 42 EKGs, but guess what?
Yeah.
Well, and here's the thing that kills me. There will be crews that will take serial vital signs, and then the only one that they put in the chart is the initial one.
Mm-hmm.
And then in their narrative, they'll say, "Oh, patient remained awake, alert, stable, and talkative throughout transport." Okay, you
That's
can
not a complete set of vitals, dumbass.
well, that's the thing. You can say in the narrative whatever the fuck you want, but clinical presentation and proof, such as vitals. Now, yes, you have, you can make up vital signs if they're not uploaded. What the fuck ever. The point is, if you don't have trending vital signs, a minimum of two, I would argue three. So one at patient side, one during transport, one like as you're parking.
Mm-hmm.
That is a fucking minimum. That is a minimum. That is a trending set of vitals that you can prove the patient was clinically stable, regardless of them talking. I have patients who had a BGL of like fucking 30 that were talking. Is that stable? Is that appropriate? Do they get no interventions? Absolutely not. I'm not saying stick a BGL, stick a
Mm-hmm.
patient for a BGL 3 times, but like heart rate, oxygen. There have been patients that have been in the 60s that are sitting there talking to me and not looking, cyanotic. She's a wild lady, but it happens. It
it,
happens.
but and it comes back to, if you don't document it, it didn't fucking happen.
Yeah.
You should be writing your chart with the mentality that as soon as you close it, it's going to the desk of an attorney.
Yeah.
That is how you should approach writing your charts. No matter what your style is, no matter how like uber detailed you are or aren't, that is how you should be tactically looking at your chart writing and how you
Mhm.
document things and doing the literal bare minimum of your job.
Mhm.
It's not fucking hard.
Well, and
Because
double documenting was covered in EMT school. Like I don't
all of this is.
I don't understand why this is still a fucking conversation.
When you have when you permit practices like this on your ambulances, and you don't take proper corrective steps with people, and it would up to and including firing them, this is the kind of stuff that happens. And it sets you up for bad, bad, bad shit to happen. You allow people who have bad habits to perpetuate those habits in their own life and to the people around them, because we do not operate in a fucking vacuum. In
Mhm.
this job, who you work around has a direct impact on your performance as well. So that standard should be sky fucking high, because if it's not, we're all going to drop to the lowest common denominator.
Well, and here's the thing, when it comes to like partnerships and everything, if there's a issue with the partnership, obviously talk to the partner. But there are times where you're going to have people like a partner that I've referenced in the past, or the people that we've talked about, where even if you talk to them, they basically say, "Well, I'm not changing. This is just who I am." First of all, toxic as fuck and is also childish. Stop being a kindergartner.
Mm-hmm.
But at that point, talk to your supervisor and request a new partnership, because eventually you're going to pick up those bad habits, because it's like, well, why am I going to keep killing myself to do the job appropriately when they're literally like not doing anything?
And you're going to lose a lot of good people by tolerating and not dealing with those problem people, because a
Mhm.
lot of good people are going to say, you know what, I don't give a damn how much you're paying me. I
Mhm.
don't give a damn what your protocols are, how nice your trucks are or aren't.
Mhm.
I'm not putting up with this, because there's
Yeah.
no incentive. And not that you should have to have incentive to do your job well, but when you can get paid and treated better somewhere else for doing your job, people are going to go there.
Mhm.
But when you have a culture where you tolerate these kinds of things, you're setting yourself up to be in the news, which, strangely enough, is kind of our next big topic,
Mhm.
and I think is going to be quite interesting, because we talked last time about the Sioux City paramedic who gave rocuronium instead of ketamine to a patient.
Mhm.
And we're not wanting to rehash all the details of that. We did find out some more information. Actually, family members of the patient have spoken to a friend of ours, which I won't divulge those details, because that's his story to tell, not ours. But they have been verifying what's in the news. I want to throw in the caveat, disclaimer, whatever you want to appear. We are not attorneys.
No.
We are not students of criminal, civil law, none of it. We are people who have worked in an industry that is overshadowed by lawsuits, by depositions, by everything.
Liability-based medicine.
We've worked for places that practice liability-based medicine.
Mm-hmm.
We have been immersed in this a lot, and so we're wanting to speak from experience, not to be arbiters or pontiffs on these things, but to give just a down-to-earth perspective on this and some application.
Mm-hmm.
Filling in a couple of details regarding the call. I know we had said for the initial news report we had read that the details were very vague on the patient's complaint presentation. But in this other article that we found, it's on the SiouxLandProud.com. It's a local news in the Sioux City area, local news outlet. They said that the patient was found, quote, freaking out and laying in the street rolling around. And then officer at the scene was able to determine that the patient wanted medical assistance, even though he, quote, was not making any sense. So you have a patient, 26-year-old male, who is in obvious distress. There's no documented history of substance abuse or behavioral chronic behavioral issues. That's not just a, hey, sir, you need to calm down. Like, you need to be handling that patient very carefully and respectfully.
Well, and something that we don't exactly want to get into is which drugs are best, because ultimately it's going to come down. It's going to come down to your protocols. Now, without vital signs, we can't determine if this was a psychotic break, if it was excited delirium. We
just don't know.
We don't know. We weren't there. I will say if it was excited delirium, with hypertension, hyperthermia, ketamine was the wrong drug of choice. Period. You should have gone with like a B52 shot. But again, we don't know. It could just be that for behavioral period, their protocols are ketamine. So I mean, there's always, everyone is going to run this type of call differently and choose, Ativan, Versed, B52, ketamine, whatever.
Well, and so it describes a little bit, and again, this is all allegedly. So we're reading that in the context of the news article, which the news article states allegedly for all of this. But it states that the paramedic allegedly chose to give the patient ketamine to try to calm him down. After going to the ambulance, she came back with a syringe and gave Foster a shot in the arm. So this is one of those situations where we've all done it, but in reality, this is not how you should be doing this. Because what should have happened is there should have been a med check ultimately on scene. Obviously, if you're in danger, I'm not going to be like, hey, can you stop running from this guy chasing you and confirm this is the right medicine? No, we live in a dynamic environment, and sometimes you just have to do shit. However, you should at the very least, as a paramedic, be triple checking what you're drawing up.
Well, and it's not even like it's Benadryl and Zofran that have the same colored tops, and you don't look at the color. Like, oftentimes the paralytics literally say paralytic on the top, and even if they don't, can you read?
Yeah.
Like,
I mean,
were you able to make it through paramedic school and take NR EMT without reading? Like, at minimum, read the vial. Ketamine is not spelled anywhere close to rocuronium.
Yeah.
I can understand like a dosage error more than like a complete hey, this cap says, paralytic.
Yeah. Well, and as you and I were talking beforehand too, once you realize the mistake, this is not a complicated situation to manage. Your patient's not moving. They're not fighting with you anymore. So you can ventilate them. In theory, and again, this is armchair quarterbacking. We weren't there. But just with the details that we have in front of us, that kind of a situation, if you and I were in that situation where we inadvertently, some fucking how, gave a paralytic to a patient intramuscular, it's easy enough to secure an airway. Whether you choose to follow through and just make a complete RSI out of it, even though you're way out of order, or you give a sedative and just ventilate with basic airway adjuncts until they come back around,
Mhm.
whichever one. You can manage the airway. Hypoxic ischemia should not be
Ever
happening.
be a thing. Yeah, it should never be a thing.
You're talking about a 26-year-old male. I guess in theory could have been grotesquely obese and been a little bit difficult to bag, but this is not somebody who, has and again, I don't know what this patient looks like. I'm just throwing that out there. There could be some physiological factors that make ventilation difficult.
There's always exceptions to the rule.
Right, but in general, this is what paramedics do. What have we historically been? We've been airway warriors. Manage an airway. That should be your number one priority. ABCs. And yet, that allegedly is not what happened here.
Mm-hmm.
It's sad. I mean, first obvious thing, it's sad, but this is the kind of thing where there's no way to paint that isn't your fault.
Mm-hmm.
And she is being charged as of right now with involuntary manslaughter. Apparently with the law. What do we say there in Oklahoma? No, where is Sioux City? I can't remember. I have to go back and look. Iowa. Sorry, God, we had this last time. They're in Iowa.
Oh, that's
so
right,
apparently, the punishments that she could be facing is up to 2 years in prison and a fine of $8,540.
Okay, I'm not gonna lie, that's not nearly as much as I would have expected.
No, and actually, I looked. If my mouse will work, it's been being approved today. But it's technically in Iowa considered an aggravated misdemeanor.
For someone's loss of life?
Involuntary manslaughter. So basically they're saying it wasn't deliberate, it wasn't murder. It was involuntary. So the same would happen if someone, if I accidentally ran over somebody in my car. Like I wasn't going out my way trying to find them, but I accidentally ran over them and they died. And I mean, that's
well, yeah, but on the medicine side, I would think withholding airway, if they found it to be credible, I would think that withholding airway would be outright negligence at that point, even if they panicked.
Well, and apparently she was just arrested. So this article was from the 20th.
So 3 days ago.
Yeah, so she was arrested on Friday. That's why all this stuff started popping up.
Mm-hmm.
And so we kind of want to talk a little bit. Just again, this is an opinion piece, and would welcome conversation, comments, feedback. Like, this is a shitty situation all around.
Mm-hmm.
So when I'm looking at something like this, my first thought is, okay, what are the underlying causes for what happened? As best we can. What are the potential reasons for an error like this to occur, or just inappropriate treatment in general? There's a couple of your basic ones. Obviously, is you have a lack of proper equipment on your ambulance, or just poor quality equipment that fails.
Mm-hmm.
Those portable suction units that aren't usually worth a damn. Anywhere you work.
The really old, like, squeezy ones where you're like...
Man, I haven't seen one of those in a while.
Oh, God. I saw one a year ago.
Oh, I mean, I know they're still around. I don't object to them inherently, but it's a little interesting. So, I mean, you can have, lack of or poor quality equipment. You can have outdated protocols.
Yeah.
And that's still very, very common.
That's unfortunately very prevalent in this area.
Yeah, so in that sense, there's inappropriate treatment. Even if you're following protocol, it can still be inappropriate treatment in light of evidence-based medicine.
You mean we're not giving 20 mics of dopamine anymore?
There's a failure to properly check off or resupply the ambulance or whatever unit you're operating on, which that falls on the individual. Well, the first two you could argue falls on the agency. I'm not responsible for the fact that my boss decided to dumb down our protocols. I'm not responsible for the fact that they can't fork out cash for a monitor charger. I'm not talking about my place of work because we have those things. Yeah, just saying. You're not responsible for that.
It's not their fault if all the drugs expired and they haven't been able to because of around here we have
national shortages.
Well, the fluid shortage because of the North Carolina damages and everything was pretty legit.
Well, but I'm talking over the years. I've always heard, well, why don't we have this? It's a national shortage. Okay.
Yeah, even though everybody else has it.
Yeah, literally everybody else around us has it.
Well, and when it comes to stocking an ambulance, if you have a partner and somehow something still got missed by two fucking people, like that's That's a
Mm-hmm.
problem. You should be checking off the truck together. If you're one of those lazy partners that's like, oh, my partner's super thorough and they did it. Well, maybe today's the day that they needed a nap and decided not to check off the truck, and then you catch an oh shit call and you're missing like half your stuff
Yeah.
because the previous shift sucked at restocking.
And then then you can also have an accidental medication administration error. So you just and many of us have had this happen in some way, shape, or form.
Usually it's more so dosing than like the wrong med.
No,
though.
I agree. And I mean that I have had happen.
Because of concentrations and
Yeah.
stuff.
We're just talking about what can cause inappropriate care, period. We're not even talking about in the context of a lawsuit, just the things
Mhm.
that can go wrong.
Mhm.
And then you have people who intentionally misuse medications on patients. And this I just think is absolutely despicable. People who will abuse ketamine on
Mhm.
patients. Or, I mean, you could argue this is, quote, accidental. I would say it's more negligent, if you're giving a milligram of Epi 1-to-1 through an IV.
Yeah.
I'm sorry, you
I
are
mean-
grossly. There is
I mean,
no
even-
excuse.
But I mean, even giving 1 milligram 1-to-1 IM, like, know
Well,
your
yeah.
fucking doses.
Yeah, like Epi 1-to-1 on its own should never touch an IV.
Mhm.
Ever. Dilute the shit out of it. Anyway,
Now,
welcome to my TED Talk.
again, we know shit happens. It's the unfortunate, part of the job. But that's where med checking comes back, and
Mhm.
giving the wrong med. I feel, I could be wrong, but statistically, I feel is less common than the wrong dose, especially if you get like a new whatchamacallit, concentration of the drug.
Mhm.
I had a med error. Technically, it wasn't mine. It
We
was
talked about this with was it the mag?
Yeah, with the
Yeah.
mag.
Yeah.
Technically it was mine. I took responsibility for it because I was the lead paramedic on the truck. But I told my partner that I wanted 2 grams. Yeah, I think I said that I wanted 2 grams. And my partner had never seen one of the 10 ml vials. He was used to the 1-to-1 or 1 gram and 1 ml. And he literally just read that it was 10 mLs, and he just assumed that it was 2 gram concentration, drew up the whole thing. Well, when he handed me the 10 cc syringe, I said, did you dilute this? Because I only wanted 2 mLs. I should have specified,
I
or
think it
not
was 4 mLs.
sorry,
Yeah.
2 grams and 4 mLs.
Yeah.
I should have said the whole thing. I didn't. I should have asked to see the vial. I didn't. Put it in the bag, ran it in for a respiratory call. It wasn't until we were already transporting and I sat down to finally reassess everything that the vial rolled to me and hit me in the elbow, and I saw it was empty, and I didn't panic. Granted, this was a big old lady, so I'm pretty sure she did great with 5 grams. But the
Great
point
absorption.
is, she did great. Her respirations on that CPAP were fan-fucking-tastic, but that's not the point. So when we get to the hospital, as soon as he opened the doors, I was like, what the fuck did you give me? Did you give me the whole thing? Or did you draw it up, waste it, and then dilute it? Because I had asked him if he diluted it. And he had told me, yeah. So I said, how many grams did you give me? I gave you 2 grams. I said, how many mLs? He's like, 10. I didn't say anything. My face had to have said it. And he was like,
face has no filter if you can't already tell. Stop.
you're being
So mean. No.
Stop doing that on camera. Whatchamacallit. But it's one of those things no, it didn't hurt the patient, but if we'd gone weight-based dosing with no max, it was probably an appropriate dose. So go in, give a report to the doctor. I told him exactly what happened. I was taking serial 12 leads, all the things. So patient outcome wasn't bad, but you have to own up to it immediately. And, it turned into an incident report. So no one is above concentration med errors.
Mhm.
That's why, I verbally med checked my partner, and he was a paramedic that has more years of experience than me, but I didn't look at the vial. So even when you half-ass med check, the things can still happen.
And this is why we harp so much on the whole complacency subject, because the more complacent you are about medications, the more likely this kind of stuff is to happen. So again, we don't know this medic. We don't know what their norm is, but there's a number of points of failure here that are clearly a problem. So the question that emerges from this discussion, and I think this is where things get a little more polarizing in the public service world, is should EMTs and paramedics be personally liable for lawsuits from inappropriate treatment? And again, there needs to be due process. I cannot emphasize that enough. You cannot even begin this discussion without making sure the due process is followed, without proper documentation of everything. I would say that in a situation like this, yes, you need to look at the agency in general. What kind of safeguards do they have in place for medications? Um what kind of protocols do they have? Do they need to look at splitting up their narcs and their RSI meds? Like, there's some evaluation on that level, but when it comes to you drew up the meds and you pushed the syringe, at that point, there is no room for, oh, they weren't properly trained on this or, whatever.
That's the point of being properly trained, because we've heard the argument of, during the due process and the subpoenas and everything, that we need to see training records and we need to see in service and ongoing education, this and that. But it comes down to, if somebody is certified as an EMT or paramedic and they're working within their scope of practice, they have met the national minimum standard.
Mm-hmm.
I don't fucking care what their continuing education is. Drug names and mechanism of action, the fact that Rock is a paralytic, was covered in paramedic school.
Yeah.
It doesn't matter what your the mechanism of action doesn't change with ongoing education and training.
Well, and med checking is not like this perishable skill.
Mm-hmm.
Like, you either do it or you don't. And it is beat into your head in paramedic school.
Mm-hmm.
That's what you should do.
Mm-hmm.
It is established that this is the way. So do it.
Or, well, if it's not beat into your head, you need to find a better program.
Well, yeah. So to me, at that point, it's irrelevant what the agency does. If you are stepping onto that truck as a paramedic, you accept responsibility for every single medication that is on it, and you accept responsibility for either knowing off the top of your head what the dosing is, or being able to verify it quickly, which I believe in doing as often as possible. Like, I will do it even if it's a med that I'm confident in a lot of times, unless it's, your standard, respiratory call. We've literally done this 1,000 times. No, I'm not going to look up the dose for aspirin. I know how much aspirin to give. Like, but I'm saying, especially if it's meds that you don't give often, go look at the protocol real quick.
Well, especially with like AHA, for example, changing like Adenocard from 6 to 12, and some agencies are following suit and doing 12-12 or doing 6-12-12 or just doing 6 and 12.
Mm-hmm.
Agency to agency, you need to verify your protocols, especially if it's a recent job change for you. But if you can read and you pass EMT or paramedic certification, you are responsible for any action that you do. And at minimum, it's reading the medication vial and knowing at minimum that you at least have the right medication.
And it's not like a situation where it's, oh, you should have gone with, Versed instead of ketamine. No, we're talking about two categorically different drugs.
Mm-hmm.
Like, there's no, like, room for, oh, this was just a lapse in judgment. No, you grabbed the wrong fucking vial and you didn't fucking read it.
Mm-hmm.
Period. You can't argue that. So, in that kind of a situation where they're true, outside of someone just having a pure psychotic break, which if they were, I would think they wouldn't be, as coherent enough to still run a call. But outside of something crazy like that, you know that stuff, and you are personally, I believe, you should be personally liable for that.
Mm-hmm.
If you take an action that, and let me clarify, you do an inappropriate treatment without properly treating it and compensating for it, and the patient has a negative outcome from it,
mm-hmm.
yes, you should be personally liable for that.
Mm-hmm.
Now, are there times where you do an inappropriate treatment, let's say, Like we talked about my thing with the Versed. Okay, that was technically an inappropriate treatment,
Mhm.
but the context, the patient was already managed.
Mhm.
Their airway was already managed. There was
Mhm.
zero detrimental, effect on the patient.
Mhm.
If anything, it was just more of the effect that we were trying to achieve already because it was the right medication to the right patient.
Mhm.
That's one thing, but when you actually have, in this case, and I think we read, I can't remember how detailed the statement was we read last time, but in here it specifically gives that the coroner said the patient died, quote, due to global hypoxic ischemic encephalopathy and cardiac arrest due to administration of rocuronium.
So I mean,
So,
basically, it's you paralyzed the patient and didn't give them oxygen.
yep,
I mean, that's the
that
layman's
that's
terms.
because
Ter- terms.
because if you did treat that patient appropriately, your first priority would have been oxygenating them.
And I would hope sedating, but yes.
Well, yeah, I mean, but obviously, first thing is we got to
Is
manage
oxygen.
airway
Yeah.
because sedation be damned. But ischemia happens when you're not getting oxygen,
Mhm.
and if it's enough that you die 2 days later from it, that airway was not managed appropriately. That is an assumption, but that is a reasonable assumption simply from those facts alone, not to mention the additional comment from the prosecutors in the case.
Well,
And,
and the coroner that literally determines cause of death.
well, yes, I'm just saying as far as like to backtrack and say, okay, well, we can verify through this that they didn't manage the airway appropriately.
Mhm.
Technically, that is an assumption. That is an extrapolating assumption. However, it is a very reasonable assumption.
Mhm. Well, and obviously with due process and everything, the fault has to be proven beyond reasonable doubt.
Yes.
Which, I don't know if anybody watches Criminal Minds or Law and Order SVU or whatever,
We're SVU
the
attorneys. We're not real attorneys. We're SVU attorneys.
Stop. There's actually SVU.
I'm saying the show SVU.
Yeah.
Calm your Titaws, everybody.
Come here, titties. Whatchamacallit. Obviously, the burden of proof fault. What?
Just thinking of an individual that you and I both used to work with who left being a paramedic and went to be a sheriff officer. Littler fella. But one of my favorite moments from him, I can't even remember where we were, but he literally just like, everybody just calm your titties. It's okay. It's fine. Just calm your titties.
I mean, I'll tell Kaylee that, but that's
I
fine.
know, but just the way he did it, how animated he was, and the context is like, oh my god, this is hilarious. Anyway, that's all that was playing in my head just now.
You're fine. Obviously, the burden of proof, proving fault falls on prosecution. So, I mean, the defense has the ability to cast reasonable doubt. And again, we preface we were not there.
Mm-hmm.
But the general.
You know why I do this to you all the time.
Yes, I know. But the general process is it's pretty damning to give the completely wrong drug that's not even in the same medication class. And, if, beyond reasonable doubt it is proven, the provider is found directly at fault, they should be held to the fullest extent of the law. Like, oh, well, they're a paramedic, it's in a high stress job. If anything, you should be not really paranoid. I don't want to say paranoid, but like you should be extra sure that you're giving the correct medication. If you can't handle the stress, maybe this isn't the field.
Yeah. When we say that there needs to be proof beyond reasonable doubt, not only, well, I mean, that's a given, obviously, for deeming anybody guilty,
Mm-hmm.
but there does need to be an evaluation in general in these kinds of lawsuits of making sure that the agency did not have a contributing factor to this.
Well,
And
or the hospital, because I mean we've seen that too.
Well, yeah. I think to me there's kind of two different phases with that. One with when if it's the agency's fault, so the agency gave you inappropriate equipment, inappropriate protocols, all of that. The agency should be held accountable, and that agency should be covering any legal counsel fees for the provider who was initially involved in the lawsuit.
Mm-hmm.
Again, just my personal opinion from an ethical standpoint, I think that's a bare minimum statement.
Mm-hmm.
But what I have a problem with, and I can't speak from experience that this has actually happened to me, but it's something that I have a feeling probably has happened, where EMS did everything by the book.
Mhm.
Everything that they could.
Brought in a shit show.
Yep. Actually, this almost happened to someone we know.
Mhm.
But anyway, where the hospital tries to push the blame of the death of a patient onto EMS.
Oh, I know here.
Yep.
Yeah.
Yep. And that to me is fucking despicable.
Yeah.
That is beyond fucking despicable. That is no different than someone who gives an appropriate med trying to blame shift onto their partner that it was their fault. No fucking different. Should be fucking illegal. And if you're found doing it, you should be prosecuted to the fullest extent of the fucking law
Well, I
too.
mean, there are some. I'm pretty sure there are some states that if somebody cries rape and then it's unfounded and then it comes out that they made up a rape accusation, that they can actually be charged for it.
Which
Because I
they
mean,
should.
yeah, which when you have allegations like that, whether it's child abuse or molestation or rape or whatever, if it's a truly false allegation, they should be held liable. Well, same with blame shifting with the hospital. If it's found that they're at fault, but then they try and blame shift onto EMS, yes, technically shit rolls downhill, but like if the hospital is found to have held treatment and EMS did everything that they possibly could and have appropriate documentation, like that should be illegal. That should not be okay.
Yeah, I mean, because and I think a lot of that stuff gets gotten away with because was that even right? A lot of people get away with that. That's probably more the proper term to word it.
Mhm.
A lot of people get away with it because hospitals have lots of expensive attorneys.
Yeah. Well, and
A lot of
doctors tend to have their own
Mhm.
what is it, liability insurance or whatever? Malpractice
insurance.
insurance.
Yeah. But a lot of these ambulance services, they can't afford that same legal counsel. I mean, maybe some counties can, but hospitals are really good at the liability game, and I think that
Finding
I
loopholes.
think that has been used to their advantage too many times.
Yeah.
Can I come here and provide you with a case number and those kinds of details? No. Do we know that kind of shit happens? Have we seen those kinds of things take place? Abso-fucking-lutely.
I guarantee you probably know somebody that it's happened to, whether it's, openly known or not.
Or the hospitals will use that as leverage
Yeah.
to get rid of employees, even though that employee may have done nothing wrong. Or if they did do something wrong, it was a negligible offense compared to what the hospital did. And obviously the next thought from all of this is well, we're getting scared of losing our jobs. Yeah, you should be scared of losing your job. You're being handed scheduled drugs that can take away people's ability to breathe. You're being given drugs that can basically kickstart a heart. Sorry to quote Motley Crue. You're being given some very, very, very powerful shit.
I mean, even giving fluids to the wrong person, you can drown a patient with CHF or flash pulmonary edema.
You can give them a fucking stroke. Like,
yeah,
you carry such a variety of tools that can cause a lot of damage.
I mean, even EMTs if you give too much nitro, you can bottom out the pressure. I mean, every certification level with paramedics and electrolytes and different pressors and everything. I mean, you can literally fuck up somebody's chemistry with some sodium and mag, or if you give too much calcium, glucagon. I mean,
it's and really, if you break it down, because I mean, what does everybody in public service? What does everybody focus on? Law enforcement, and law enforcement, shoots this person, kills this person, beats this person, all that stuff. Just about every single drug you have. Almost every single, not every single one, but almost every drug you have on your ambulance can be used in a way to hurt somebody, or and lethally. I mean, you give if you were to give someone like me an amp of Epi 1 to 10, you'd probably kill me, or at the very least put me in the fucking hospital for heart issues for the rest of my life.
Well, I mean, what is everybody told? If you give too much albuterol, it can cause a calcium imbalance, which calcium affects and causes dysarrhythmias. I mean, even giving if you have long QT syndrome, giving, 8 milligrams of Zofran can cause torsades. I had a brain fart there for a minute.
It's fine.
Even the most basic stuff can potentially cause problems. Withholding oxygen, giving too much oxygen, and having your free radicals. There's all kinds of arguments there. So I I don't want to say like you should get on the truck every day and be paranoid, but like you need to take it seriously. Like I know we talk about how, you have been given special permission to enter into somebody's home, in the worst day of their life. And like yes, that's true. But we also need to respect the fact that even EMTs are allowed to give drugs. They can hurt
Yeah.
people. And if you do something with negligence, then you should be held liable. Now, there are times with shit happens. You give a little bit too much of a drug. Like, should it have happened? No. Should you be doing med checks? Yes. But like misdosing is still I don't exactly want to say more okay, but I would rather give a little too much Versed to a patient that I'm giving Versed to than giving a paralytic versus, a sedative.
Yeah. It's
And we're not perfect. We have
no, God no.
given you two very easy, simple examples of when we have been part of misdosing. But like you should be at minimum verbally, like I did, checking that it is the correct medication. I should have looked at the vial because I knew the 10 ml syringe that didn't look right. Now, there's a reason behind that, which is a whole other story. But like don't just verbally med check because you can have people that mix drugs weird, that give you the wrong concentration, even though it's the right drug. We should be checking each other and not getting complacent because you need to be consistency versus complacency.
Well, and I will guarantee you that this paramedic didn't wake up that morning for her shift thinking, oh, I'm going to, end my fucking career today.
Mm-mm.
No, like you never think about it that way. I would say that there is a healthy level of paranoia. Balanced with confidence that has been reinforced by competence. So if you are actively increasing your competence, you should be gaining increased confidence because you know what you're supposed to be able to do. You know what all your options are. But you need to treat it with respect. There is a healthy paranoia. When you crack that drug seal, on any medication really, but especially for narcotics, when you crack open the seal in that box, you need to be prepared for every single thing that happens to come back on you. And cross your T's, dot your I's, all of it. Triple fucking check. I'm one of those guys that if I'm walking into a public bathroom, I'm literally watching the sign as I walk in to make sure that I'm walking into the correct one.
Oh God, me too.
I
don't want to walk in. If I see a urinal, I'm like, oh shit.
Yes. Call me old fashioned. I like to use the correct bathroom. But I check the sign. And same with medications. Look. Okay, let me make sure. Let me look. Okay, cool. Like, be careful. Be careful. Be confident. Be aggressive when you need to be. Be cautious when you need to be. Not every patient requires you to bust in like a bull in a china shop and just start barking at people and making, shit happen. Sometimes you just need to shut the fuck up.
Says the lawnmower. Well, and with that is where I would say consistency.
We're ready for a couples therapy session on that.
I'm
teasing. No. Well, and we've talked about that on the show. That when it comes to, every couple has those days where they need to work through some stuff, and I tend to be, a lawnmower. I see a problem, and I'm like, I just want to run over it, and Michelle is not the, delicate, helpless disposition. But in that situation, more like a flower who has a lawnmower approaching that says, wait! Don't! Stop! And I'm like, well, what's wrong? Oh, there it goes. There's the pedals. Whoops. But, so anyway.
This is the line of the problem? Step over.
Oh, that's a line? Oh, that's cute. Anyway. But when it comes to patient care... walk in absorbing everything, leave your assumptions at the door, which is hard. I know. I've struggled with that before. Be willing to apologize to your patients when you do. That's a tough pill for anybody to swallow. Be willing to apologize to your patients to their face. But treat this with respect. I'm so tired of you people. I say you people. The vocal ones who are demonstrating that they're incompetent. I get so tired of the carelessness with which we talk about this job. No, I don't think you need to be, Mr., like you're a funeral home director every time you show up to work. But but treat it with some respect because you have an incredible amount of power in your hands.
Mhm.
And if you don't respect it, it will come back and bite you in the fucking ass.
Well, and practicing consistency, even
Mm-hmm.
consistency in how you do your patient assessment, how you say hello, how you fucking chart, taking a minimum,
How you document vitals.
yeah, minimum of 3 vitals. Like, I mean, seriously, people, how fucking hard? Bedside, transport, destination. Takes 30 seconds.
Yep.
It's not that fucking hard. We're not even going to talk about how many EKGs I took on my patient last night.
Yeah.
Anyways,
Yeah.
but I mean, doing it consistently, because like if you do like med checks consistently, it becomes second nature. And yes, you can argue that second nature turns into complacency, but that's why you need to actively be practicing, checking.
Mm-hmm.
You could argue that's why, even if it's only once a year or, once every 6 months, work with somebody different just to change it up.
Yep.
Don't get complacent with who you're working with and start BLSing calls because, oh, they're a strong partner. Like, fuck you.
Yeah. That's not how that's supposed to work. You should be building them up with correct mentorship,
Hmm.
correct clinical decision making, not, oh, you're my buddy, you can handle this, I believe in you. No.
You can tell me if something goes wrong.
Don't be so complacent that you train bad habits into your partners
Hmm.
and chronically risk major liability issues with your patients.
Hmm.
Just don't do it. Don't do it.
Well, I just want to, I guess, recap. Um, work with different people, even if
Yeah.
it's only one shift periodically. Like, work with other people, shake it up. Don't get complacent. If you feel entitled to work at the same station, at the same truck, with the same partner, fuck you.
We love you, but fuck you.
Hmm.
Anything else you want to throw in for the boys and girls out there?
No.
Well, if you learned something, good. Tell your friends about it. If you were offended, good. You probably should be. Do better. Be consistent. Put your patients first. And we'll talk to you guys next time. Bye bye.